is non-adherence is not determined by the class of drug prescribed, aspirin, blood pressure lowering drug, statin, suggesting that the side effects are not the major driver of non-adherence, but you probably already know that. Individual adherence to antihypertensive medications. So the range, depending on study, is from 30 to 70%. African Americans in general have been shown to be almost 2 to 4 times less likely to be adherent. Several studies have shown that medication use is lower in Hispanics, but this is not due to adherence. This is due to the fact that they need fewer drugs to control blood pressure. And the adherence rates among Asian American and Pacific Islanders are, if you take a look, 50% to 65% among Japanese hypertensive patients. And if you remember back the slide about 8 Americas, the very first line was Asians. Surprisingly enough, even though that they have the longest life expectancy, their adherence isn't all that great when you take a look at this subfraction of that population. You've already seen this slide was presented by Dr. Lee in a different format with that, patient, but it's basically the same 5 dimensions of non-adherence. And this is to emphasize, again, the complexity of adherence overall, namely that even within each one of these factors, there are individual sub-factors that are involved, and I'll comment on them a little bit and probably too superficially. What strikes me is that this is such a complex issue that 15 to 20 minutes is just not enough time to develop a particular idea, but that's not a complaint, that's just an observation. So let's take a look at some of those patient factors, okay? The psychosocial and behavioral factors in particular, and knowledge. If you take a look at those, here are some interesting things. And although this slide is pitched as a difference between African Americans and whites, focus on the white column. I found it tremendously surprising that the trust in patients of doctors is as low as it is. Take a look at this. 56% of white patients feel that insurance companies push generics to save money at the expense of my health. That 27% of whites feel that most medications are addictive. And of course, every one of these categories is a little bit higher in African Americans and in other subgroups of the population. So we have, and here what is crystallized here is that internalized attitude, belief, cultural aspect of adherence that drives health behaviors in general, not only pill taking. Health literacy contributes to that, and it's one of the hidden problems. We can assess education. When I went to see my physician some years ago, and because I needed a more regular checkup when I reached that magic age where I felt that more care is better, he had me fill out a form and how many years of school, etc. That's easy to collect. But the fact of the matter is that it doesn't stop there. And one of the consequences of low health literacy is that people might feel ashamed in discussing issues with their physician, their provider, their pharmacist. They may mask their shame to maintain their dignity, and therefore that limits one's opportunity to help them. And we have to be aware of that. How big of a problem is this? If you take a look at how many are below basic health literacy, 14% of the general population, and at basic health literacy, 29%. So we're looking at essentially, if you want to extrapolate probably inappropriately, you're looking at 43% of the population have modest health literacy, and maybe that is the 43% that's non-adherent. I'm sure there's not that close a relationship, but there's probably a correlation. And if you take a look at this, high school grads, 52% have basic or below, and then as you go age of 65, 61%. So health literacy is quite an important factor in all of this. And what is the consequence? Greater emergency room use, less likely to engage in disease prevention, poor medication adherence, and then you get down to the economics. Inadequate care, increased costs, poor health outcomes, increased risk of mortality. And I'll come back to the economic issue with not a solution, but a question, which I hope that people in this room may be able to give. To come back to health literacy and interactions and trust in the provider and so forth, here's some data on the style of communication in race discordant and concordant interactions. So here's a case where you have collaborative, so the dark blue line represents an interaction in healthcare that is concordant. So both parties, the patient and the physician, are the same race. The light blue line shows discordant. So if you have good collaborative, I should probably be pointing to this, but I must admit it's easier to look in this direction. I think it has to do with the fact that my neck isn't as flexible as it used to be when I was a little bit younger. So when you have collaborative interactions, the race concordance does not matter. You have pretty much the same kind of result. But if you have a discordant and non-collaborative, then you really have a problem. So basically, what this tells you is the quality of communication really matters. And a focus on that, a self-examination of ourselves as we interact, is one of the important features. Surprisingly to me, eliminating co-payments has only about a 5% improvement in adherence. And I thought for most of my life that the big issue is poverty, ability to pay, access to health care. And although they all have an influence, it's not the only influence, and maybe a much smaller influence than we would like. Automated pharmacy, I'm trying to hit the pointer. Automated pharmacy outreach for statins. So you can see that automated outreach, phone calls, mailings, et cetera, automatic refills and so forth, can have someplace around 2 to 3-fold improvement, depending by age, in adherence to lipid-lowering drugs. Blister packs, including multi-use drug blisters. And what surprises me here is I was actually surprised to find that such a thing exists, that you can actually uniquely for a given patient cluster drugs into a blister pack, and so which should make the regimen much simpler. I have a number of relatives in my family who are elderly and who have a whole tray full of pill bottles, but I've never seen any of them get this. Now, to me, it seems like an economic thing. I mean, the first impression that I get when I look at this is that there's a cost involved. But I'm willing to bet you, at a pretty good, odds ratio, that the cost involved in this is pennies. And if you take a look at the billions spent on medications, at the profit margin of medications, and at a 50% non-adherence, this cost is trivial. I'm not an economist, but maybe I'm missing something here. But it seems to me that this cost, in comparison to the profit that could be made from selling more drugs and having better adherence, is completely trivial. And I think that the health economic issue is one that we have to look at more realistically than I feel has been looked at. How effective is this? if you take a look at this particular randomized design, blister packs improve adherence. They move it from a little bit over 60 to nearly 100%. Discontinued blister packs, it drops down, whereas another continued pharmacy care, blister packs improve adherence, and as long as you continue, it continues adherence. So this is a no-brainer. This definitely has an impact. Mail order pharmacy services. Another one that I did not expect, but it turns out that mail order pharmacy services actually improve adherence, not dramatically, but a little bit, and every little bit helps. But this is not for everyone. Some patients do not like it. And perhaps they do not like it because there's not a safe place to receive mail order drugs. They may distrust them. They're not sure that they're going to arrive. Maybe it's going to be too hot. They'll sit in the, the post box and get heated and lose potency. There are a variety of things. So it's not for everyone. But for those that accept it, it's probably a very good idea. So here's the sobering results. And I really don't like to give negative. I think that it's important in order to diagnose the problem in order to have solutions, we have to have a realistic look at where we stand right now. And the truth of the matter is, you've probably all here know what the Cochrane collaboration is. They are the premier meta-analysis group worldwide. And this particular review, which was just published in 2014, methods of improving medication adherence are mostly complex, not very effective. Effects are generally small. Even with strong methodology, no consistent evidence exists that medication adherence can be improved with resources usually available. There's no evidence that low adherence can be cured. It's not as if we will find the magic wand, cure adherence in a given patient, and then you're done for the rest of their life. It's probably an ongoing problem, which is part of the reason for the title of my presentation as well, The Perpetual Frontier, as opposed to the Final Frontier. So this is what all three of us have been talking about so far, which is that it's a complex system between the healthcare system and the patient, and all of that ends up over here with treatment received. And I want to end with a note on something that I learned recently that I thought was absolutely fascinating. This is an engineering friend of mine who said this is a classic example of impoverished data on a huge intractable problem with poorly defined hypotheses for which we have no useful tools or interventions. It's maybe a little bit of an overstatement, but given the fact that over the last 30 years we have moved from a 50% adherence to a 50% adherence, maybe it's not too far off the mark. But here's the example that I want to give you and leave you with this particular question. So you've all heard that now there's Medicare has instituted a 30-day readmission rate that is deemed acceptable, and organizations, hospitals, clinics who fall below a certain standard are fined. They're penalized to some extent by the amount of reimbursement they get. So one of my colleagues, and I can't tell you much about this study because they're just beginning to analyze the data and it's intended to be published, but the basic concept I thought was very interesting. So this particular hospital took a look in a major academic center, took a look at their 30-day admission rates, and they were going to lose a lot of money. And so the strategy that they undertook is to form several teams to analyze what actually goes on, because heretofore what they had been doing is reporting out. Every quarter they report what their 30-day admission, but they never did anything about it. So they formulated several teams, and the teams essentially had to analyze, what goes on. They used this foresight approach, and you can find this on the web. There are different ways of doing this, but this was a very interesting one. There were different people who were assigned by self-report of their propensity to prefer certain kinds of thinking and activities. And they made sure that each team included people who clarify, ideate, develop, this is a great word, isn't it? Develop, implement, etc. And each team created a solution for that organization in that context, in their department. Okay? The bottom line is that actually at least one of the interventions made a spectacular difference in 30-day readmission rates. So my sense actually is, and this is what I want to bring to you to ask yourself, given all the individual differences among patients, among healthcare providers, geographic locations, subgroups of the population, shouldn't the solutions also be within the subgroups, within your own organizations, at your own level? What we have been striving for is kind of a national solution. Let's find a hammer that works for everyone, and then we're in the clear. And maybe that's just not realistic. Maybe we need to focus down to our own local community, our own local organization, analyze all these different aspects of what's contributing to non-adherence, find a local solution, implement it, study it, do a randomized intervention, try one solution versus another solution, figure out which one is the best. And it could be that we have been just reaching too far out too quickly rather than focusing on the individual differences and the organizational differences that may be involved. So I'll leave with the conclusion that maybe this research field needs advances, including improved design, long-term interventions, and the analysis, which I did not put in here, at the local level in order to find the most optimal solutions. And I thank you for your attention.
Thank you, panel, Leah, Peter, and Kirby for those stimulating presentations. We do have some time for questions, so please, if you have a question, just stand up and Elaine will bring, or raise your hand, and Elaine will bring you the mic. We want to make sure we hear your question and that we can record it as well. There we go.
Hi, Dr. Lee, I have a question for you. Do you have any specific studies that you can cite that show that motivational interviewing, specifically you mentioned that motivational interviewing, and how that increases adherence? And then also, do you have any articles or anything about cost savings related to motivational interviewing and with adherence?
So that's a good question. I have colleagues who are experts in motivational interviewing. I'm not, but I can find sources for you. I would say that motivational interviewing itself is just one part of the multi-component intervention. So I wouldn't rely on motivational interviewing alone. Very good question. Or, I don't know.
Yeah, I can add. So I know one of the colleagues that hello? Yeah. One of my colleagues at Duke, Hayden Bosworth, has actually had several randomized clinical trials that have motivational interviewing as one component. So one of the studies that he's just published on is called CITIES. It's an acronym for an incredibly complex name. But if you look in PubMed, you can find it. That might be one place to start.
Other questions? Marcela?
Thank you. Marcela Gaitan with the National Alliance for Hispanic Health. Looking at the information that we got in terms of using technology, but also looking at not everybody has access to the technology. A lot of populations do not use still technology. Do you know if there are any research to looking at, for example, I'm thinking about Hispanic families, multi-generational Hispanic families, where you can look at like the kids probably helping the grandparents with technology, and that could be used as a way to perhaps improve adherence as you look at how families can support the older generation being supported by the younger generations, and in this case using technology, for example. Because when we look at, I would think it would be the same for maybe African American and Asian families, where you see the grandparents still just maybe beginning to use some technology, but then the kids, the younger people, are completely adept at technology, using mobile, apps and things like that. So I don't know if there is any research or maybe perhaps an opportunity for that.
Yeah, so there is research showing that actually simple interventions, so while we have smartphones that can do wonderful things, simple interventions like an SMS text message, a telephone call, particularly for people who might be unfamiliar or avoiding technology, or engaging a family member or a caregiver who actually uses technology. So these are all good strategies to use, but take-home message is that the technology should be simple enough to make it easy for whoever the user is.
Some of the information you mentioned, so just bring to everybody's attention. Again, September 5th,
Jerry
Washington
Debbie,
Post,
California Chronic Care Coalition.
author Leonard
Just
Bernstein,
information
researchers are
for
trying
everyone.
again
The Washington
to take
Post,
medicine. It's all about medication
on
adherence.
September 5th, wrote an article about medication adherence.
Any other
Researchers are
questions,
trying again to help
comments,
you take your
information?
medicine.
Brian
And
Warren
we
with
have
the
a lot of
California
information
Pharmacists
here for
Association.
consumers
In
as
your
well.
research, did you
Some
find
of the
there are
information you mentioned, so
more or
just
less
bring to
effective
everybody's
ways of
attention.
measuring adherence? Some are based on
in
medication
September
possession
5th,
ratio, which doesn't
Washington
necessarily
Post,
mean they're taking it, it just means they
author
have the
Leonard
drug.
Bernstein,
Also,
researchers
some
are
of them
trying
are
again to
self-reported.
help you take your medicine.
And then I
It's all
think
about
perhaps even more
medication
importantly,
adherence.
are any of them looking at strategies that towards improving adherence that actually look at health outcomes? Because it's not just about taking the medications, it's about taking the right medications that are having the right impact.
Brian Warren, the California Pharmacists Association.
So that's actually a really, really important question that is a current limitation of most of the research out there is how are we measuring adherence and how are we measuring clinical outcomes? And I think I don't have an answer for you, but I think you're very fortunate because I think Dr. Ferris is speaking this afternoon about ways to measure adherence, but it should be beyond the simple, are you adherent or not? You can figure out if someone's adherent, but then get at the reasons for why they're adherent. And if we can come up with more specific measures that do that effectively across populations, across disease states, and across systems, I think we can make a much more headway in tackling the problem of non-adherence.
Sure. So I absolutely agree. We've actually done an interesting study, which we didn't publish, but looking at long-term effects of some of our interventions just by looking at electronic health record data. And it's really fascinating to see some of the things that seem most effective in the short term maybe aren't in the long term. And some other things are very easy for patients to keep up with on their own. So I think, as Kirby said, some of the simple solutions do potentially work best. But I think it's important that we as researchers really build in long-term outcomes. That's tricky to do with some funding strategies right now. But
One of the things that's concerned me is that when we do literature searches on this, a lot of the significant things that are happening within the payer world that they are evaluating, and then, for instance, CareSource is an MCO that is managed care organization working with Medicaid in Ohio. They have had such good results where they're seeing a $4 savings for every $1 they pay the pharmacist for medication therapy management, that they're expanding it and asking our pharmacists to do more with their 1 million patients in that program. Same thing with Anthem Health. When Barry Malinowski, who was our physician medical director 4 years ago, had a project in Cincinnati where the A1Cs for the city of Cincinnati were at 50% on their diabetics. When the pharmacists got involved, it went to 75%. But I guess I'm just wondering on those kinds of pieces of research, which to me are very important because it influences a payer to pay the pharmacist to do the activity, that's not always picked up in these, discussions. And I didn't know how those things can become either better known, or are they not really scientifically, valid? They certainly are to them because they're seeing a payment change, but not really sure whether my question is clear, but it's something that I'm seeing out there that unless the pharmacists get paid for those activities, the chains won't allow them the time to do the activity.
I don't have a comment on that, but I can appreciate the problem. It is exactly, I mean, it's a fact that you described, that there's a economics issue in much of this. I did want to comment on an issue that has come up a couple of times this morning, and that is on the relationship between adherence and clinical outcomes. And as I was thinking about that, I realized that I don't know of any studies that had as the primary objective an understanding between adherence and clinical outcomes. But if you take a look at most clinical trials that are, for example, examinations of strategy of one kind of drug versus another, or intensity of treatment and so forth, of necessity, they monitor adherence very closely in order to remove that as a possible confound in the work. And all of those trials do show a very close correlation between adherence to a medication and things like, for example, serum lipid levels. So as a matter of fact, an excellent example is the lipid research clinics